All right, so we're diving deep today into the World Health Organization's AWARE book.
Aware.
Yeah, it stands for Access, Watch, Reserve. It's all about antibiotics. And we're tackling Chapter 25, Sepsis in Neonates and Children.
Sepsis. Always a challenge.
It is, and as medical microbiologists, you're dealing with this every day. But are we really up to date on the latest definitions, diagnostic approaches? I mean, this chapter had some surprises for me, especially when those clinical presentations are tricky, you know, not your classic sepsis picture.
Right. It can be so subtle, especially in those tiny humans.
Exactly. So let's start with definitions. The book makes a clear distinction: neonatal sepsis, under 28 days old, and then pediatric sepsis, 28 days to 12 years. Clinically, that makes sense. But microbiologically, what are the nuances there? What makes that distinction so important?
Well, it's not just about the bugs themselves. It's about the host response. Neonates, they're so immunologically immature, they can react very differently to the same pathogen. Compared to, say, an older child.
Right, their immune systems are still developing.
Exactly. And then there's a way they acquire these infections. Think vertical transmission during birth.
Oh yeah, that adds another layer of complexity for sure.
It does.
Okay, so the book also brings up this alternative definition: possible serious bacterial infection, or PSBI. It's almost like they're moving toward a more clinical syndromic approach.
Yeah, especially for resource-limited settings. I think that's key. They're focusing on what you can actually observe.
Clinical signs.
Right, clinical signs. Difficulty feeding, convulsions, rapid breathing, things you can see.
In those settings where you might not have all the fancy lab tests right away.
Exactly.
So how does this PSBI definition stack up against those traditional sepsis scoring systems, like SNAP-E2, for example?
Well, SNAP-U and those other scores, they still have their place, but the book points out their limitations.
Especially in those resource-limited settings.
Yeah, there just haven't been enough validation studies in those contexts.
Makes sense.
And they actually suggest exploring alternative scoring systems. Things like the CRIB score, the Clinical Risk Index for babies, which might be more appropriate for LMICs.
Interesting. So it sounds like there's a lot more research to be done in that area.
Definitely.
All right. So first exam question. Get those mental pencils ready.
Uh-oh.
A neonate presents with a temperature of 34.8 degrees Celsius using the PSBI criteria. Would this alone be enough to suspect a possible serious bacterial infection? What do you think?
Well, this is where it gets tricky, right? PSBI isn't about just one sign in isolation. It's the overall clinical picture.
The whole baby.
Exactly. So while hypothermia, yes, it's a red flag, it needs to be considered along with other signs. So in this case, the answer is no, not enough on its own.
Exactly. You nailed it. Okay, moving on to clinical presentation. And the book is very clear about this. Sepsis in these little ones, it can be sneaky.
Oh, yeah, especially in neonates. It can mimic so many other things. What looks like a simple feeding issue could actually be
the start of something serious. So what are some of those red flags?
Yeah.
The things that should make our spidey senses tingle.
For neonates, well, we just talked about hypothermia.
Yeah.
But also lethargy, poor feeding, apnea.
Those are all pretty non-specific, though.
They are, which is why it's so challenging. And for older kids, you might see altered mental status, changes in behavior, the more classic signs of infection like fever, tachycardia.
Right, those are the ones we're all taught to look for.
Yeah.
And then there were those WHO danger signs for newborns. Stop feeding, convulsions, severe chest indrawing. I mean, those are like
big red flags, yeah. Immediate action needed.
Absolutely. Early recognition and referral are crucial, especially in those resource-limited settings where things can escalate quickly.
Definitely.
All right, let's talk lab tests. I mean, this is where you folks shine, right? But even for seasoned medical microbiologists, there's always something new to learn.
True. And what I found interesting in this chapter is their emphasis on a tiered approach to microbiology testing. In an ideal world, you'd have the full suite, right? Blood cultures, urine cultures, CSF, maybe even a chest x-ray if there are respiratory symptoms.
But that's not always the reality.
Exactly. And the book acknowledges that. It guides us towards prioritizing tests based on clinical suspicion. So for example, if meningitis is high on the list, lumbar puncture takes precedence.
That makes sense. Prioritize based on what you're suspecting.
Right. Yeah.
Second exam question. Imagine you're in a resource-limited setting, dealing with a neonate suspected of having sepsis. You can only do one microbiology test. What do you prioritize and why?
Oh, okay. Let me think. Given the high mortality associated with neonatal sepsis and the limited resources, I would have to prioritize a blood culture. It offers the best chance of identifying the causative organism.
To guide antibiotic therapy.
Exactly.
You nailed it. Blood cultures are often the most revealing, especially when those broad-spectrum antibiotics need to be tailored quickly. Now let's move beyond the microbiology lab. What are those other lab tests that the book highlights as crucial in the context of sepsis?
So it's about looking beyond the bug itself, assessing the host response, a complete blood count, for example. That can reveal leukocytosis, neutropenia, signs of the body fighting infection,
Right.
C-reactive protein, procalcitonin. Those are helpful markers of inflammation, although they're not without their caveats, of course.
Always caveats.
Always. They also bring up the PSOFA score. Is that replacing those traditional pediatric sepsis scores?
Not really replacing them. The PSOFA, it stands for Pediatric Sequential Organ Failure Assessment. It's more about assessing organ dysfunction.
In critically ill children.
Yeah. So while it can be used to gauge severity, it's not a diagnostic tool on its own. It's more about risk stratification, guiding those decisions about escalating care. Interesting. So it's another piece of the puzzle. Okay, third exam question. Which of these is not a component of the PSOFA score? A, platelet count. B, Glasgow Coma Scale. C, blood glucose level. D, systolic blood pressure.
Okay, so this is where you have to remember those specific components, and the correct answer is C, blood glucose level. While it's important to manage in sepsis, it's not part of the PSOFA calculation. The score focuses on those organ systems: cardiovascular, respiratory, hematologic, liver, central nervous system.
Exactly. It's easy to get those scores mixed up.
Yeah, there are a lot of them.
Now, what about imaging? Does the book have like a whole algorithm for when to order a CT scan versus an ultrasound?
Thankfully, no. It's very practical. They really emphasize that imaging should be targeted, driven by the suspected source of infection.
Not just ordering every test under the sun.
Exactly. Always balancing the potential benefits against the risks, of course, especially radiation exposure.
In these little ones.
Yes.
So if a neonate has respiratory distress, a chest x-ray makes sense.
Yeah.
But if we're concerned about a UTI, the abdominal imaging.
Right. It's all about clinical reasoning.
Okay, I like that. So it's about empowering the clinician to make those informed decisions.
Exactly. And that includes medical microbiologists.
Absolutely. Speaking of, let's jump into treatment. Now, you live and breathe antibiotics, but the AWARE book has some specific recommendations for neonates and children with suspected sepsis.
Right. It's all about finding that balance between broad coverage and targeted therapy.
So let's start with neonates who can be referred to a hospital. First line of attack.
The book recommends either intravenous ampicillin plus gentamicin or intravenous benzylpenicillin plus gentamicin.
Oh, those are the first choice treatments.
Right. And it's because they offer that broad coverage against the most common pathogens while we wait for those culture results to guide us further.
And they're very specific about dosages and durations.
Oh, yeah. It's all laid out clearly.
Ampicillin, 50 milligrams per kilogram every 12 hours for the first week of life. Then every 8 hours. Gentamicin, 5 milligrams per kilogram once a day. But here's where the AWARE part comes in, right? Because not every setting has access to those IV formulations.
Of course not.
So what's the backup plan when referral isn't an option?
Well, they recommend a really practical alternative: oral amoxicillin plus intramuscular gentamicin.
Right.
Amoxicillin 50 milligrams per kilogram every 12 hours for infants under 2 months. Then every 8 hours. And the gentamicin stays the same, 5 milligrams per kilogram once a day.
So they've really thought of everything.
They try to.
Okay, fourth exam question. Real-world scenario. You're in a rural clinic with limited resources. A 10-day-old neonate presents with signs of possible sepsis. Referral is not an option today. Based on the AWARE guidelines, which antibiotic regimen would you choose and why?
Okay, in this scenario, I would definitely go with the oral amoxicillin plus intramuscular gentamicin. It's accessible, effective, and most importantly, feasible in that resource-limited setting.
Exactly. The AWARE guidelines are all about adapting to the reality on the ground. Now, before we get into those trickier cases where initial treatment fails or there's resistance, let's do one more exam question about those first-line choices.
Okay, I'm ready.
All right, so a 3-week-old neonate is brought to the hospital with suspected sepsis. Blood cultures are drawn, and they start empiric antibiotic therapy. Which of these combinations is not a recommended first-line treatment option according to the AWARE guidelines? A, intravenous ampicillin plus gentamicin. B, intravenous ceftriaxone plus amikacin. C, intravenous benzylpenicillin plus gentamicin. D, oral amoxicillin plus intramuscular gentamicin.
Oh, this one's tricky. You have to really pay attention to the details.
It is tricky.
The correct answer is B, intravenous ceftriaxone plus amikacin. While they are effective antibiotics, that combination isn't considered first line for neonatal sepsis in these guidelines.
Exactly. They're usually reserved for those second-line situations where the initial treatment isn't working. So let's talk about those second-line scenarios. What happens when those first-line antibiotics just aren't cutting it?
Then we need to escalate, up the antimicrobial game.
And the book doesn't leave us hanging. They've got those second-choice options laid out. For neonates, it's either cefotaxime, ceftriaxone, or a combination of cloxacillin and amikacin. And they even break down the dosages. Cefotaxime at 50 milligrams per kilogram every 8 hours, ceftriaxone at 80 milligrams per kilogram once a day. Cloxacillin at 25 to 50 milligrams per kilogram every 12 hours.
Wow.
And then amikacin is added to that mix at 15 milligrams per kilogram given once a day. But here's where your expertise comes in, right? Choosing the right second-line agent, it's not just about following a recipe.
Right, you have to consider the clinical picture.
Those local resistance patterns.
And any preliminary culture results, if they're available. It's like being a detective.
I like that analogy. So we could spend hours dissecting every antibiotic regimen. But let's shift gears and talk about the pathophysiology of sepsis. This is where things get really interesting, especially in those tiny humans.
It really is fascinating, the interplay between the pathogen, the host's immune response, and the timing of that exposure. And neonates, they're just so vulnerable.
Right, where they're developing immune systems.
Exactly.
And the book doesn't shy away from this complexity. They emphasize that sepsis in neonates is not just a bug getting in, it's a whole cascade of events that can quickly spiral.
Yeah, it can get out of control very quickly. You have these immature immune systems trying to fight off invaders while also developing and maturing at the same time.
And then you factor in those perinatal exposures, like prolonged rupture of membranes or maternal colonization with group B strep.
Right.
And that can further tip the scales towards sepsis.
It really is a web of interconnected factors.
It is, and understanding those nuances, it can make all the difference in how we approach both diagnosis and treatment. The book also cautions against something important: overdiagnosis and overtreatment.
Yeah.
Especially in neonates.
Right. It's a good reminder that not every febrile neonate has a serious bacterial infection.
Not every fever means sepsis.
Exactly. We need to be judicious with our antibiotics, always balancing the urgency of treatment with the potential harms of overuse.
Speaking of overuse, the book dedicates a whole section to antimicrobial resistance, which, as you know, is a global crisis.
It is a constant battle, and we're on the front lines.
They highlight those multi-drug resistant organisms, especially in hospital settings.
They're everywhere.
It is a sobering reminder of the stakes involved in managing sepsis.
It really is.
Before we delve into the epidemiology of sepsis, let's take a quick detour back to those second-line antibiotic options for older children.
Okay, yeah, let's talk about them.
So, beyond the neonatal period, 28-day-olds to 12-year-olds, the AWARE book recommends similar second-line choices as for neonates: cefotaxime, ceftriaxone, or that cloxacillin and amikacin combo.
Yeah.
Again, those dosages are adjusted based on the child's weight.
Right.
And the ultimate choice depends on clinical judgment. And of course, those pesky local resistance patterns. It's like this book is our trusty field guide, helping us navigate the ever-changing landscape of sepsis management.
I like that analogy.
Okay, so let's zoom out a bit now. Talk about the global impact of sepsis.
Right.
And this is where the numbers get really heartbreaking. Sepsis is a leading cause of death in children under 5 worldwide, especially in sub-Saharan Africa and South Asia. It's just a stark reminder of those health disparities that exist around the world.
It is.
And the book doesn't hold back when it comes to outlining those risk factors: prematurity, low birth weight, maternal infections during pregnancy, all those perinatal exposures we talked about earlier.
Right, it's like a chain reaction.
It is. And breaking those links, that's key to reducing the burden of sepsis. Okay, before we move on to those microbial culprits, let's take a moment to just appreciate the complexity of diagnosing sepsis in these young patients. The book really paints a vivid picture of the challenges clinicians face.
It's not always clear-cut.
It's not.
Those subtle signs, the overlapping symptoms, the mimics, it's like solving a medical mystery.
It is. So let's break it down by age group. What are those telltale signs that might make us suspect sepsis in a neonate?
Well, in those first few weeks of life, you have to pay attention to those subtle cues. Temperature instability, whether it's a fever or hypothermia, that's a big red flag. Then you have the feeding difficulties, lethargy, changes in breathing, even something as simple as the baby being off their usual color.
Okay.
Those can all be signs.
And for those older kids, do the signs become more clear-cut?
You'd think so, but not necessarily. While fever and chills might be more common, you still have those nonspecific symptoms: fatigue, decreased urine output, changes in mental status.
Okay, so it sounds like a keen eye and a high index of suspicion are our best tools in these cases.
Absolutely. And the book really emphasizes that, considering the child's medical history, any underlying conditions, the context of the presentation, it all matters.
Right, it's not just looking at the symptoms in isolation.
Exactly.
Now, I know we've touched on this before, but it bears repeating. Those WHO danger signs, those are like the emergency flares of neonatal sepsis.
Yeah, if you see those, you need to act fast.
Stop feeding, convulsions, severe chest indrawing, fast breathing, abnormal temperature, jaundice in those first 24 hours.
It's go time.
All right, we've painted the clinical picture. Let's get to the nitty-gritty of lab tests, the bread and butter of your work.
Right. Lab tests are crucial for confirming that diagnosis, identifying the specific pathogen, guiding our antibiotic choices. It's all about precision medicine, even in these tiny patients.
And the book walks us through those essential tests: blood cultures, complete blood counts, C-reactive protein, procalcitonin, all those markers of infection and inflammation. And they address those tricky situations where resources are limited.
It's a reality for so many.
They guide us towards prioritizing tests, making the most of what we have. It's about being adaptable, isn't it?
It is. Resourceful, strategic, especially when those lab capabilities are stretched thin.
Now, before we get into the specifics of antibiotic treatment, I want to emphasize something the book hits on repeatedly: supportive care. It's not just about nuking those bugs with antibiotics, right?
No, absolutely not. Supportive care is the foundation. Oxygen therapy, fluid resuscitation, close monitoring of those vital signs. We need to support those tiny bodies while they fight.
Their immune systems are working overtime.
They are.
And sometimes that supportive care might involve more intensive measures: mechanical ventilation, medications to stabilize blood pressure.
It's about individualizing that care, responding to the patient's needs as they evolve.
All right, before we wrap up part 1 of this deep dive, let's talk about those microbial villains, the most likely pathogens behind all of this. Now, you could probably rattle off a list of bugs in your sleep, but I'm curious, are there any surprises in the book's breakdown of pathogens?
What I found interesting is their emphasis on context. You have to consider the child's age, any comorbidities, and their geographical location when you're trying to pinpoint those most likely culprits.
So it's not a one-size-fits-all approach.
Not at all. It's about understanding the nuances. For example, the bacteria in a neonate with congenital heart disease, it might look quite different from a healthy 3-year-old.
Oh, for sure. And those multi-drug resistant organisms, they're always lurking, especially in hospital settings. The book dives deep into that world: ESBL-producing bacteria, MRSA, even those scary carbapenemas-producing organisms.
It can be daunting.
It is. And it's not just about knowing they exist, right? It's about understanding their prevalence in your region, their susceptibility patterns, how to combat them effectively. It's like you're playing a game of microbial chess.
You said it. We're constantly trying to stay one step ahead, anticipate their moves, have a plan B, maybe even a plan C, up our sleeve.
Well, on that note of microbial warfare, we're going to wrap up part 1 of this deep dive.
Back for more, ready to tackle those multi-drug resistant villains.
Absolutely. Let's break it down by age group. What are we seeing in neonates? Those classic pathogens, ND, the rising stars of resistance.
So for those brand new humans, the usual suspects are still the big players: E. coli, Staphylococcus aureus, Group B strep.
Those are the classics.
But even within those, we're seeing a shift towards more resistant strains. The book specifically calls out extended spectrum beta-lactamases, those enzymes that can break down so many of our go-to antibiotics.
Penicillins, cephalosporins.
Exactly. It's like they have a secret weapon.
And then there's MRSA, methicillin-resistant Staph aureus. It feels like that's been a problem forever.
It has, and it's not going away anytime soon. The book emphasizes that in settings with high MRSA prevalence, we might need to rethink our first-line antibiotics, especially for those infections that look like staph.
So vancomycin might be stepping up to the plate more often?
It might. It's a watch antibiotic, so we need to use it judiciously. But sometimes it's the only option we have left.
The book also mentions some differences in pathogens, depending on whether the infection is community-acquired or hospital-acquired. Are those lines blurring at all in neonatal sepsis?
They are, more and more, especially with so many babies being born in healthcare facilities now. What was once a clear distinction is getting muddled.
Makes sense.
And those hospital-associated pathogens like Klebsiella, Cinetobacter, they're showing up in unexpected places.
It's like the microbial world is constantly adapting.
It is.
Okay, what about those older kids? Does the bacterial lineup change much once we move past that neonatal period?
It does a bit. Streptococcus pneumonia becomes a major player causing pneumonia and meningitis. We also see more group A strep and Neisseria meningitidis.
Meningococcus.
Yeah.
That one always gives me the chills.
It can be very serious. Progresses so rapidly.
It does, which is why recognizing those early signs, like the petechial rash, is so important.
Absolutely.
Now, the book also mentions some pathogens. That might not be on our radar as much in high-income settings, but they're major players in LMICs.
Right. In those regions, you have to think about things like non-typhoidal salmonella, especially in kids with underlying conditions. Malnutrition, HIV, it can cause invasive infections that are really tough to treat.
And of course, those multi-drug resistant organisms are a concern everywhere.
They are. ESBL-producing bacteria, carbapenemose producers, those are the real game changers. They make treatment decisions incredibly complex.
It feels like we're constantly playing catch-up.
In some ways we are. That's why research into new antibiotics and alternative therapies is so crucial.
We need new weapons in our arsenal.
We do.
Okay, so we've painted a pretty bleak picture of the microbial landscape. Let's talk about treatment. The book has some very clear recommendations, but how much wiggle room is there? Is it ever okay to deviate from those guidelines?
The guidelines are a great starting point, but they're not meant to be followed blindly. They acknowledge that clinical judgment matters, so do local resistance patterns and individual patient factors.
So it's not just about memorizing dosages and durations.
Right. It's about understanding the principles behind those recommendations and applying them thoughtfully. For example, the book might give you a very specific dosage for ampicillin, but if you're dealing with a neonate with kidney problems, you might need to adjust that.
You have to see the whole patient, not just the lab values.
Exactly. The lab is a tool, but it doesn't tell the whole story.
Now, the book also talks about this concept of de-escalation. Can you explain what that is and why it's so important?
So de-escalation is all about refining our antibiotic choices. Once we have more information, initially we might start with broad-spectrum antibiotics to cover all our bases, but once those culture results come back, we can often switch to something more targeted, a narrow-spectrum antibiotic.
It's like starting with a shotgun approach and then honing in with a laser.
That's a great analogy. De-escalation helps us to minimize the development of resistance, reduce the risk of side effects, optimize treatment outcomes.
Makes sense. Speaking of the right antibiotic, the book introduces this framework called the AWARE classification. I have to admit, I got a little lost in the acronyms. Can you break it down for us?
It's not as complicated as it sounds. AWARE stands for Access, Watch, and Reserve. Access antibiotics, those are the workhorse drugs. They should be widely available, affordable, and effective against common infections.
Our frontline soldiers.
Exactly. And then you have the watch category. These are the valuable drugs, but we need to protect them from overuse. They're important for treating specific infections, but they also carry a higher risk of resistance development. So we need to use them strategically.
Not just throw them at every infection.
Right. And then there's the reserve category. Those are the last resort antibiotics. We only use them in dire situations, like when we're dealing with multi-drug resistant organisms.
It's like a tiered system of defense.
It is.
Okay, I like that. Now, the book also throws us a curveball. Those cases where differentiating between severe malaria and bacterial sepsis can be a nightmare.
Oh, yeah. That's a tough one, especially in malaria endemic regions. Those overlapping symptoms can make diagnosis incredibly difficult.
So how do we navigate those murky waters?
The book recommends a cautious approach. Basically, treat for both possibilities until you have more definitive answers. So you would administer both anti-malarial medications and broad-spectrum antibiotics.
You're erring on the side of caution.
You are. But in these cases, it's better to be safe than sorry. Delaying treatment for either condition could be devastating.
Okay, so we've talked about treatment, but what about prevention? The book dedicates a whole section to the importance of preventing these infections in the first place.
Prevention is always the best medicine.
So what are some of the key strategies they highlight?
Vaccines, for sure. Vaccines against Haemophilus influenza type B, Neisseria meningitidis, Streptococcus pneumonia, typhoid fever. Those can significantly reduce the risk of infections that can lead to sepsis.
Those are some heavy hitters.
They are, and they've made a huge impact.
The book also stresses something so simple: Hand washing.
Right. Hand washing is so basic, but it's amazing how effective it is.
It really is. And then there are those broader public health measures. Access to clean water, sanitation.
Those are fundamental,
Yeah.
especially in resource-limited settings.
Right, improving those conditions can dramatically reduce the risk of infections.
Definitely.
And we can't forget about breastfeeding.
Breast milk is amazing. It provides those babies with the antibodies they need to fight off infection. It's nature's protection.
And the book also gets into infection prevention and control measures in healthcare settings.
Yeah, that's crucial for preventing those hospital-acquired infections. Hand hygiene, proper use of PPE, isolation precautions, meticulous cleaning and disinfection. It's all about creating a culture of safety.
A culture of vigilance.
Exactly. Every step we take to prevent infections can potentially save a life.
Okay, so we've covered a lot of ground in this deep dive into sepsis. But before we wrap up this part, I want to circle back to something you mentioned earlier, antimicrobial resistance. It's a threat that's not going away. And you, as medical microbiologists, are on the front lines.
We are. And it's a challenge that keeps me up at night. We're seeing those resistance patterns evolve, making treatment decisions harder and harder.
The book talks a lot about antimicrobial stewardship, using antibiotics wisely, responsibly, to preserve them for future generations. What can medical microbiologists do to champion that cause?
We have a big role to play. We can educate our colleagues, advocate for policies that promote stewardship, stay informed about the latest research and the guidelines for managing resistant infections.
It's a team effort.
It is. Clinicians, microbiologists, pharmacists, infection control specialists, policymakers, we all need to work together to tackle this global challenge.
Okay, so we're back for the final round of our sepsis deep dive. From those tricky definitions to the ever-evolving world of pathogens, and of course the ongoing battle against antimicrobial resistance.
We've covered a lot of ground. It's been quite the journey. But before we wrap up, I wanted to shift gears a bit. Talk about the human side of sepsis.
The human side.
Yeah. As medical microbiologists, we get so focused on the science, right? Identifying those bugs, figuring out their weaknesses, guiding those treatment decisions. But we can't forget, behind every lab result, every data point, there's a real person, a tiny human, fighting for their life.
It's a powerful reminder. It's easy to get lost in the data and forget the human impact of what we do.
It really is, and that's why I think it's so important for us as medical microbiologists to be more than just lab experts. We need to be advocates, educators, collaborators. We need to work hand in hand with those clinicians, nurses, families, everyone involved in the care of these children.
The Aware book touches on that as well. They emphasize the importance of clear communication, a multidisciplinary approach to sepsis management.
It really does take a village. To combat sepsis, we need to share our knowledge, our insights, our passion for improving the lives of these kids, these vulnerable children.
Speaking of passion, what keeps you motivated in the face of such a complex and often heartbreaking challenge?
You know, for me, it's those small victories. Seeing a child recover from a severe infection, knowing that our work in the lab, it played a role in that outcome, those are the moments that fuel my drive. To keep learning, keep researching, keep pushing the boundaries of what we know about sepsis.
Those small victories can make all the difference, and I think that's a perfect note to end on. We've explored the science, the challenges, the triumphs of this battle against sepsis in neonates and children.
But the fight continues.
It does. And to all our listeners out there, remember, you are on the front lines of this battle. Your expertise, your dedication, your unwavering commitment to these tiny humans, it makes a world of difference. Keep asking those questions. Keep pushing for better diagnostics, better treatments, and never, ever underestimate the power of your knowledge to save lives.
Well said.
That's a wrap for today's deep dive. Until next time, stay curious, stay informed, and keep fighting those microbial villains.